We present a video on the hysteroscopic removal of intrauterine devices in pregnancy. Intrauterine devices are a common form of contraception. While pregnancy is uncommon, first-year failure rates are 0.8% for the copper IUD and 0.2% for the levonorgestrel-releasing intrauterine system. Pregnancies complicated by a retained IUD are at increased risk of adverse outcomes, most commonly spontaneous abortion and preterm labor. To date, multiple studies have documented reductions in these risks following IUD removal in early pregnancy. As a result, the World Health Organization recommends IUD removal at the earliest gestational age possible, when the strings are visible on exam. However, if the strings are not retrievable, what are the options for management? When pregnancy continuation is desired, there are three approaches to management: expectant management, removal with a grasper under ultrasound guidance, and hysteroscopic removal with or without ultrasound guidance. This video will present 4 cases to highlight steps and technical tips in successfully performing this procedure. First, ensure pregnancy continuation is desired and obtain informed consent. Complications are uncommon, but risks of gestational sac rupture and miscarriage are discussed with all patients. Review preoperative imaging to plan your surgical approach, and before the procedure, we confirm viability and administer a single dose of cefazolin. This animation depicts the steps of the procedure. The first step is vaginoscopic hysteroscopy using a 3.8 or 5 mm continuous flow hysteroscope with a 5 French operative channel. The second step is IUD localization. If the IUD is not easily visible, or if it is located near the uterine fundus, ultrasound guidance is recommended. Ultrasound guidance can help identify the IUD and facilitate step 3, IUD removal in an uncomplicated fashion. Case 1 is a 35-year-old Gravida 2 Para 1 who had a copper IUD removed at 9 weeks and 6 days under ultrasound guidance. Hysteroscopy is performed without cervical dilation. Upon entering the endometrial cavity, the gestational sac becomes visible. Visualization is challenged by extensive mucus and debris that mixes with the limited infusion of saline distension media. A hysteroscopic grasper can be advanced through the operating channel of a hysteroscope and used as a probe to help identify the IUD. Once located, the IUD is grasped firmly to ensure it is successfully removed on the first attempt. We attempt to keep the grasper and IUD in view until successful removal is attained. Case 2 is a 32-year-old Gravida 2 Para 1 who had a copper IUD removed at 12 weeks 2 days under ultrasound guidance. This case nicely depicts the challenges in visualization posed by extensive intrauterine mucus and debris in pregnancy. We attempt to minimize removal and reinsertion of the scope to clean the lens. Here, you can see a track created to pass the hysteroscope between the gestational sac and lateral uterine wall. The hysteroscope is advanced slowly with minimal infusion of distension media to avoid disrupting the gestational sac. The IUD is located, and again, using the hysteroscopic grasper, the IUD is grasped firmly and slowly removed. We attempt to keep it in view as the hysteroscope is removed from the uterine cavity and endocervical canal. Case 3 is a 33-year-old Gravida 2 Para 0 who had a copper IUD removed at 9 weeks and 1 day under ultrasound guidance. In this case, you see that as we obtain entry to the uterine cavity, the hysteroscope is not advanced any further. We then perform a gentle scan from one side of the uterine cavity to the other. This helps facilitate IUD identification without the need to advance the hysteroscope further into the uterine cavity. This reduces the risk of disrupting the gestational sac. This technique is useful when the IUD is believed to be located in the lower uterine segment. Case 4 is a 37-year-old Gravida 3 Para 2 who had a copper IUD removed at 11 weeks and 1 day under ultrasound guidance. This case nicely depicts how the uterine cavity is entered slowly and carefully to avoid disrupting the gestational sac, which is now seen here. Minimal distension media is again used to create a tract between the sac and lateral uterine wall. The hysteroscope is then angled up and over the gestational sac before returning to the lateral tract when the IUD is not seen. It is then advanced further along the uterine wall. The IUD becomes visible at the uterine fundus, surrounded by mucus and debris. It is then firmly grasped and slowly removed with the hysteroscopic grasper. Care is taken to retract the hysteroscope laterally against the wall of the uterus to avoid disrupting the gestational sac. To review the steps of the procedure, Step 1 is vaginoscopic hysteroscopy. Step 2 is IUD localization, and Step 3 is IUD removal. After the procedure, all patients have viability confirmed. They undergo same-day discharge with a follow-up ultrasound and visit arranged 2 weeks later. If all is well, patients and their obstetricians are advised to resume routine obstetrical care. All 4 cases had successful outcomes. Case 1, 2, and 3 all had uncomplicated pregnancies and vaginal deliveries at term. Case 4 had threatened preterm labor but delivered by cesarean section at 37 weeks and 6 days. Technical tips to help facilitate this procedure include using a small caliber hysteroscope, avoiding cervical dilation, infusing minimal volumes of isotonic distension media, and using ultrasound guidance when IUD visualization is challenging.